Hello to all of you. Today we will be discussing anatomy questions for the subject wise series, and we will be discussing from question number 21 to question 40. Myself, Dr. Shilpi Agarwal. Now in the question number 21, it is regarding the commissure, development of commissure. Now in this, if we see, the commissure which is first to develop is the anterior commissure. The anterior commissure, it develops at around 7th week of intrauterine life. And if we see that this is the one which is first to develop, if we see the location of the anterior commissure, it is present in the upper portion of the lamina terminalis. This is a section of the corpus callosum, and the anteriormost portion of the corpus callosum is having the rostrum portion. This is the rostrum of the corpus callosum. Now just near the rostrum there is attachment of the lamina terminalis towards the anterior side. This is lamina terminalis. In the upper portion of lamina terminalis there is a commissural band which is the anterior commissure. This is the anterior commissure, and it is having two components. One component, which is the anterior component, it is connecting the olfactory portions of the olfactory portions of right and the left cerebral hemispheres. So it is basically connecting the olfactory bulb, or we say the olfactory region. Now towards the posterior side, it is having a component which connects the anterior convolutions of the hippocampal area, which is towards the temporal lobe. So the portions are this portion of the anterior commissure, it is connecting the temporal lobe also. So these are the two components for the anterior commissure, connecting these said areas. Now after the anterior commissure, the next commissure which develops is the posterior commissure. The posterior commissure is the second one to develop. When we talk about the corpus callosum, it is the largest commissural fiber, and it develops during the end of the development, or we say it develops in the last week of development. So the answer for this question is the first commissure to develop is the anterior commissure, so that the answer is the B. The question number 22, it talks about the anterior horn of the lateral ventricle. Now we know that there are two lateral ventricles in each of the cerebral hemisphere. In this picture, this is the lateral ventricle. And this lateral ventricle, it communicates with the third ventricle. This is the third ventricle via the foramen of Monro or the interventricular foramen. Then further it continues into cerebral aqueduct. This is cerebral aqueduct, and it is communicating with the fourth ventricle. This is fourth ventricle. Now in the lateral ventricle, which is present in the cerebrum, it is having body, and three projections are there which are termed as anterior horn, posterior horn, and the inferior horn. Now the portion, this is the point where the interventricular foramen is present. This is the location of interventricular foramen or the foramen of Monro. The portion of the lateral ventricle which is lying anterior to this, if we draw an imaginary line over here, the portion which is anterior to this, that is this much portion, this is the anterior horn. The anterior horn of the lateral ventricle. The anterior horn of the lateral ventricle, it is a projection from the anterior aspect of the body of lateral ventricle, and it is projecting towards the frontal lobes. This portion is the body. The centralmost position over here, this is the body of the lateral ventricle. Now the projection towards the posterior aspect, this is the projection towards the posterior aspect, this is the posterior horn, and this projection is going towards the occipital lobe. Now this body over here, if you see, it is continuing below as the inferior horn. So the inferior horn is actually a continuation of the body only, and this inferior horn, it is present towards the temporal lobe. So this portion over here, this is the inferior horn, which is present towards the temporal lobe. Now so as to see the various structures which are bounding the anterior horn, we can take a sagittal section. If we take a sagittal section over here, in this picture, this is a portion where the lateral ventricle is present. The lateral ventricle is present on either side of the septum pellucidum. This is the fornix, and a membrane-like structure is present over there, which is the septum pellucidum. This membrane-like structure is a midline structure, and on either side of this septum pellucidum, we have the lateral ventricle. Now in this we have already said that if we draw a line, imaginary line crossing this interventricular foramen, the interventricular foramen is present over here. This is interventricular foramen. The portion of the lateral ventricle which is anterior to this, it will be lying over here. This is the portion which is the anterior horn of the lateral ventricle. Now in this, if we see the anterior-most portion of the anterior horn, it is related to the corpus callosum, as well as it is located towards the upper or the roof side also, and the floor also. Now it is related to the different parts of the corpus callosum. For this we should know what are the different parts of corpus callosum. If we draw this corpus callosum, the corpus callosum, it is having 4 parts. This is the body which is forming the main portion of the corpus callosum. This whole is the body. Then towards the posterior side, the expanded portion towards the posterior side, this is the splenium. This is the splenium. This anterior portion is termed as genu, and this narrow portion is termed as rostrum. So these are the 4 parts of the corpus callosum, starting from the anterior to the posterior sides: rostrum, genu, body, and the splenium. Now as you have said, the anterior horn is located over here. This is the location of the anterior horn. So from the anterior side, it will be limited by the genu of the corpus callosum. Towards the roof we have body of the corpus callosum, and towards the floor we have rostrum of the corpus callosum. So for the anterior horn, if we see the various structures forming the boundaries, towards the roof we have body of corpus callosum, and towards the floor rostrum is there. Towards the anterior side, or we say anterior wall, is contributed by the genu of corpus callosum. Towards the medial side, the medial wall is formed by septum pellucidum. And towards the lateral side, we are having a nucleus, that is the caudate nucleus. So towards the lateral side, by the caudate nucleus. These are the structures which are binding the anterior horn, and posteriorly it is continuous with the body of the lateral ventricle. So if we come back to the question says the anterior horn of the lateral ventricle is closed anteriorly, and we have already know that the the anterior boundary is formed by the genu of the corpus callosum. So the answer for this question is D, that is the corpus callosum. This picture is showing the coronal section. This triangular section is a section for the lateral ventricle. And in this, if we see towards the medial side, over here we are having a membrane known as septum pellucidum, and towards the lateral side, this over here the caudate nucleus is located, the head of caudate nucleus, so which will be forming the lateral boundary. The next question says all are seen in the floor. of fourth ventricle. So this question talks about the fourth ventricle. Now for the fourth ventricle, we know that it is present between the pons and the cerebellum. And if we specifically see over here, this is the fourth ventricle. This structure is a fourth ventricle. If we take in this section, we can see it is a tent shaped structure. The apex is towards here. This is the apex of the tent, which is towards the cerebellum, and the base is towards the brainstem. So if we see towards this side, this is the roof of the fourth ventricle, and this side is the floor of the fourth ventricle. If we talk about the roof of the fourth ventricle, towards the roof is lying the cerebellum, and between the cerebellum and this fourth ventricle, the structures which are present in the roof. Towards the upper side of the roof is basically a tent-shaped structure over here. Towards the upper side of the roof, we are having the superior cerebellar peduncles which are present over here. These are the superior cerebellar peduncles. And there is a thin membrane-like structure which is present between the superior cerebellar peduncles, and this is the superior medullary velum. Now these two structures, they are forming the upper portion of this roof. This upper portion of roof is formed by these two structures, that is the superior cerebellar peduncle and the superior medullary velum. Now we see if this is the lower portion of the roof, the lower sloping portion of the roof, towards here the inferior medullary velum is present. This is the lower portion, and again this is a thin membrane kind of structure, and this is a non-nervous tissue. This structure which is present over here, this is the inferior medullary velum. So these are the three structures mainly which are forming the roof of the fourth ventricle. Towards the upper side, these first and second structure, and towards the lower side, the third structure. The inferior medullary velum, it is having three openings. On the lateral aspects, it is having openings which are the lateral aperture, also known as the foramen of Lashka. And towards this median side, it is having one single foramen, which is the median aperture or the foramen of Magendie. And these are the foramens in the roof through which whatever CSF is coming towards the fourth ventricle, it will pass through these three apertures and will reach the subarachnoid space. Now when we talk about the lateral boundaries, the lateral boundaries of the fourth ventricle, it is formed on upper aspect by the superior cerebellar peduncle. Towards the lower side, it is formed by inferior cerebellar peduncle, as well as by the cuneate and the gracile tubercle. For the lateral boundary, if you see this picture, this is a structure which is showing the floor of the fourth ventricle, and this picture also shows the lateral boundaries. The upper lateral boundary over here, this is formed by the superior cerebellar peduncle towards the upper side, and if you see towards the lower side, this structure over here, this is forming the lower aspect, the lateral boundary towards the lower aspect, and this is the inferior cerebellar peduncle. Towards the lowermost portion over here, we have the gracile and the cuneate tubercle. So this is the first, this is the second, and these two, they are the third, the gracile and the cuneate tubercles. These are the three structures forming the boundaries, the lateral boundaries. Now towards the floor of the fourth ventricle, it is also known as rhomboid fossa. If you see in the rhomboid fossa, the various structures which are present over here, first of all, in the middle, we are having a line which is present in the center over here. This is the median sulcus. This is the median sulcus, which is a central line extending till below. The area which is on either side of the median sulcus is known as the median eminence, and the floor is mainly formed by the pons and the upper part of medulla. Now between this pons and the upper part of medulla, we can see these fibers are there which are coming like this. These fibers are known as stria medullaris. These are known as stria medullaris fibers. Now in the upper portion, if you see in this upper portion, in the median eminence there is a prominence over here, a rounded elevation is there which is known as the facial colliculus. On the either side of the facial colliculus, again one more sulcus is there which is termed as sulcus limitans. This sulcus which is on either side of this continuing below, this is the sulcus limitans. The sulcus limitans. As we go more lateral to this, we have the vestibular area. The area which is more lateral to this over this side, this area, this is the vestibular area. Now in the sulcus limitans, as we go towards the upper side, we have this triangular area which is known as superior fovea, and above this superior fovea we have a colored area, the bluish colored area which is known as locus coeruleus. Towards the lower aspect of this sulcus limitans over here, we have the inferior fovea. The inferior fovea is present over here. Now the other structures which are present over here, as we come towards the lower portion, we have two triangles in the lower portion. One triangle is towards the medial side over here. This portion is known as hypoglossal triangle. This is the hypoglossal triangle, and a portion or a triangle which is present below it over here. This is the vagal triangle. So these are the various structures which are present over here in the floor of the fourth ventricle. Namely, if you see, we have the facial colliculus, vestibular area, vagal triangle and hypoglossal triangle. Apart from this, the stria medullaris, sulcus limitans and the median sulcus. So all these structures, these are the components of the floor of fourth ventricle. Now if you come back to the question says all are seen in the floor of the fourth ventricle except. Now in this the answer will be D, because the structure which is seen is the stria medullaris. The rest of the structures are present in the fourth ventricle, in the floor of the fourth ventricle. Question number 24, it says that which cranial nerve nucleus is under the facial colliculus. As we have just discussed, the facial colliculus, it is present in the floor of the fourth ventricle, that is the rhomboid fossa. Now if we take a section in the lower part of the pons, if we take a transverse section, this is a TS in lower part of pons. Now this eminence which is present over here, this is towards the rhomboid fossa, and this is the facial colliculus which is present on either side. The nucleus which is just present beneath it is the abducent nucleus, and the nerve is exiting like this. This is the abducent nerve, and this nucleus which is present over here, this is the abducent nucleus. Now this facial colliculus which is formed over here, this is actually due to the turning fibers of the facial nerve. The facial nucleus is present like this, and the fibers as they emerge, they take a turn and then they exit. And when they are taking a turn like this over the abducent nucleus, they lead to a prominence known as facial colliculus. So this nerve is the facial nerve. And the nucleus which is present over here, this nucleus is the motor nucleus of facial nerve. So the answer for this question is beneath the facial colliculus we have the abducent nucleus, and the answer for this question will be B. Now the other nucleus which are present in the rhomboid fossa apart from the abducent nucleus is we are having the abducent nucleus which is just deep to the rhomboid fossa. Apart from this, vestibular nucleus in the vestibular area, hypoglossal nucleus in hypoglossal triangle, and dorsal nucleus of vagus is present just beneath the vagal triangle. So all these nucleus are present in the rhomboid fossa. So apart from this we have vestibular nucleus, then hypoglossal nucleus, and the dorsal nucleus of vagus also. The question number 25. This picture is showing the organ of Corti. The organ of the Corti is the receptor for the hearing, and it is present within the cochlear duct. Now if you see this picture is actually emphasizing on the organ of the portions of the organ of Corti. The various portions of the organ of Corti which are shown over here. The A over here is the inner hair cell. A is the inner hair cell. Then C is the outer hair cell. B shown over here is the spiral ganglion, which is having the bipolar cells, and the D structure over here, this D over here, this is the basilar membrane. Now whenever the cut section of the cochlea is taken, the cochlea, it appears to be round like this. This is the cochlea, the bony labyrinth portion, and in the middle of the cochlea we are having the cochlear duct, and the cochlear duct is having this triangular section. This is the cochlear duct which has been shown over here. This cochlear duct is having the basilar membrane on which the organ of Corti is resting. So this membrane over here, this is the basilar membrane, and over here this organ of Corti which has been shown over here, this is resting. And the rest of the sides, towards this side, this portion is termed as the stria vascularis. And the membrane which is opposite the basilar membrane, it is termed as Reisner's membrane. And within this portion, we have scala media, which is filled with the endolymph. So this portion, if you see, we are having inner hair cell, outer hair cell, then it is resting on the basilar membrane. This portion which is shown over here in the organ of Corti, this is termed as tunnel of this organ of Corti, and a structure or a membrane like structure is present over this. This portion is known as membrana tectoria. So membrana tectoria, this tunnel of Corti, outer hair cells and the inner hair cells, all these are the components of the organ of Corti, and among this the inner hair cells are the one which are the chief, these are the cells which are the chief cells responsible for the hearing. So inner hair cells, these are the chief cells, and the fibers from the inner hair cells, they actually go towards the spiral ganglion and they are ending on the myelinated neurons which will be forming the 80% of fibers of the cochlear nerve, 80 to 90%, and the rest are formed by these outer hair cells. So the main sensory neurons or the main sensory receptors for the hearing are the inner hair cells. Now if we come back to the question says which area is innervated by peripheral process of the spiral ganglion. So mainly the fibers, they are coming from inner hair cells, that is A. So the answer for this question number 25 is A. Now the question number 26. In this it is talking about the tendinous ring of Zinn. This is the annulus of Zinn, which is a common tendinous ring for the common origin of all the recti muscles of the eyeball. The 4 recti muscles, when we talk about this, in the bony orbit, if you see in the bony orbit, we are having a superior orbital fissure which is placed like this. This is the superior orbital fissure. And just above and medial to that we are having the optic canal. This is the optic canal. The common tendinous ring is present in such a way that it encloses the optic canal, and to other side it is attached to one of the margins of superior orbital fissure. This is the attachment of the annulus of Zinn or the common tendinous ring. The annulus of Zinn, it is a common origin point for the recti muscles, that is the superior rectus, which will be arising from the respective areas. From the superior portion, superior rectus, from the inferior side, inferior rectus, and on the either side it will be having the medial and the lateral rectus. So it is a common origin point, the common origin for the 4 recti muscles. Now due to the attachment of this common tendinous ring or annulus of Zinn, it divides the superior orbital fissure into 3 portions. It divides it into medial, lateral and the intermediate portions. So this portion over here, this is the medial compartment. The portion which is towards the outer side, this is the lateral compartment. And over here, this is the intermediate portion. Now this is the intermediate part which is enclosed by this annulus of Zinn. Now the structures which are passing through this, through the intermediate part, the nerves which are passing are, we have 2 divisions of oculomotor nerve. This is superior, the upper and the lower division of oculomotor nerve, that is 3rd cranial nerve. In between the 2 divisions of the 3rd cranial nerve, we are having this nerve which is the nasociliary. This is the nasociliary nerve, and apart from this we have the passage of the abducens nerve. So in this, if we see the structures which are passing through or within this annulus of Zinn, there are 2 divisions, upper and lower division of 3rd cranial nerve, then we have nasociliary nerve and the abducens nerve. These 3 structures are passing through this intermediate compartment. Apart from this, the other structures which are passing in the lateral compartment, we are having 3 nerves over here, that is LFT, the mnemonic for this. This one is the Lacrimal nerve. This is the frontal nerve, and this is the trochlear nerve. The lacrimal nerve, frontal nerve and nasociliary nerve, these are the 3 divisions of the ophthalmic nerve. Apart from this, we are having a vein over here which is the superior ophthalmic vein. And an artery is present over here. The artery is the recurrent meningeal branch of the ophthalmic artery or the lacrimal artery. The recurrent meningeal branch of ophthalmic or lacrimal artery. These are the structures which are passing through the lateral compartment. Now if we come towards the medial compartment, we are having only one structure which is passing through it. Towards the medial side, we are having the vein which is passing through this is present over here, and this is the inferior ophthalmic vein. So these are the structures which are passing through this, and if we come back to the question, the question says the structures which are passing through the tendinous ring. In this, the answer will be the nasociliary nerve, because it is passing through this annulus of Zinn. And the rest of the structures which are mentioned over here, they are passing through, either they are passing through the lateral compartment. The question number 27, it says the mass in the jugular foramen, it may result in all except. So for the jugular foramen, the structures which are passing through the jugular foramen, the structures are, it includes 9th, 10th and the 11th cranial nerve. Along with that, the structure which is passing through this is inferior petrosal sinus. Then we have the formation of the internal jugular vein over here. The sigmoid sinus, it continues to form this internal jugular vein. Now if there is any mass in the jugular foramen, it will cause compression of all these structures. And when they cause the compression of all these structures, it will be compressing the 9th, 10th and 11th cranial nerves. Now in this we know the vagus nerve. The vagus nerve is the one which is supplying the muscles of the soft palate, as well as pharynx and larynx. So because it is supplying these muscles, it is helping in the swallowing function, as well as it is helping in the production of the voice. Apart from this, the 11th cranial nerve, the spinal part of this nerve, it supplies trapezius as well as sternocleidomastoid. It is supplying these two muscles. So therefore, when these two nerves will be involved, it will be affecting these structures supplied by these nerves. And due to this, when the vagus nerve is involved, it leads to difficulty in swallowing and hoarseness. When the spinal part of accessory nerve is involved, it affects the trapezius and sternocleidomastoid. And this sternocleidomastoid is the muscle which helps in turning the neck to the opposite side, like this. So there will be difficulty in turning the neck to the opposite side. Now the D option says the tongue deviates to the same side. This happens when the hypoglossal nerve will be involved, and the hypoglossal nerve is passing through a different foramen, that is the hypoglossal canal, and it is not passing through this. So the answer for this question will be D. The next question is, which of the following in this is correct regarding the anomaly in the given image? Now in this picture, the anomaly which is shown over here, this anomaly is basically the double superior vena cava. The double superior vena cava is present over here. When we see the development of the superior vena cava is basically developing from the cardinal veins. This picture is showing the development of the superior vena cava. For the development of superior vena cava, first of all thing we should know is, this is the common cardinal vein which is present over here. It goes towards the posterior side to form posterior cardinal vein, and over here anteriorly it forms the anterior cardinal vein. and this is present on the both sides like this. Now between these anterior cardinal veins an anastomosis occurs or is present which connects the two anterior cardinal veins. So if we see this structure, we are having, this is the common cardinal vein and this is the common cardinal vein, this is anterior cardinal vein, and towards this side we are having the posterior cardinal vein. Now this is present towards the right side. Same kind of structure is present towards the left side. Towards left side also we are having this same structure. Now in anastomosis it occurs between the two anterior cardinal veins. The anastomosis is like this, and later on for the development of superior vena cava the portions which persist are towards the right side the common cardinal vein, then this continues into the right anterior cardinal vein, and this is the structure which leads to the formation of the superior vena cava. So the portion which extends from here till this side, it leads to the formation of the superior vena cava. The structure, it leads to the formation of the superior vena cava. Then the rest of the portion, that is the distal portion of the right anterior cardinal vein, then this anastomotic portion over here, and the distal portion of the left anterior cardinal vein. These are the portions which give rise to the right and the left brachiocephalic veins, and the rest of the portion which is present over here, that is the rest of the portion of left common cardinal and left anterior cardinal, they either obliterate or they either lead to the formation of very small veins. Over here it leads to the formation of right brachiocephalic vein, and this will be forming this whole structure from here till this side, it will be forming the left brachiocephalic vein. So now in this anomaly, the anomaly which is present over here is there is a persistence of this common cardinal vein and anterior cardinal vein. This is present, which is giving rise to the superior vena cava on the right side. Apart from this, on the left side, this whole structure is also persisting. So that on the left side also we are having the superior vena cava, and double superior vena cavas are there, and the complete formation of left brachiocephalic vein is not there. So the left brachiocephalic vein is not formed and superior vena cava is formed on both sides. If we come back to the question, this anomaly, that is a double superior vena cava, it is due to the persistence of left anterior cardinal vein. So the answer for this question is D. The next question it is regarding this picture. If you see in this, it is mentioning that the person who is having ischemia, they are suffering from the profound weakness of left upper extremity as well as a slight slurring of the speech. Now in this, if we see this area, there is a sulcus which is present over here. This sulcus is the central sulcus. And the area which is present in front of this is the precentral gyrus, which is representing the motor area. This is for the motor area, which is having Brodmann's number 4. Now if you see the representation of the body in this motor area, it is in the upside down manner, so that in the lower portion the head is represented and then the upper limbs and the trunk, they are represented in the uppermost side. The lower limb and the perineum, they are represented towards the medial surface of the cerebrum, and that specific area is known as the paracentral lobule. Now over here if we see the C area which is present over here, this portion, the C area is actually representing the head of the body, which is the lowermost portion of this precentral gyrus. Then after that, this B portion, the B portion, it represents the upper limb, and the uppermost area over here, A portion, it is representing the trunk portion. So this portion is head or the face. For this portion, this is upper limb, and this portion is representing the trunk. Now towards this lower side, if we come towards this D portion, this D portion is present below this lateral sulcus. The lateral sulcus is present over here. This is the lateral sulcus which is present over here, and this is the superior portion of the temporal lobe, or we can say the superior temporal gyrus. And in the superior temporal gyrus, either in the anterior portion the auditory area is present, and towards the posterior side we are having the Wernicke's area. So this is the anterior part of the superior temporal gyrus, and over here we are having the auditory area. Now according to the symptoms which are present, the symptoms involve there is weakness of the upper extremity. So that means this B area is the one which is involved, which is leading to the weakness of the upper extremity. So the answer for this question is B, for the 29th question. Next question is question number 30. The question number 30, it says Vasa vasorum. Now the Vasa vasorum which is arising in the case of ascending aorta, it arises from the coronary arteries. The answer for this question is A. For the ascending aorta, it arises from both the right and the left coronary artery. And when we talk about the aortic arch, the Vasa vasorum, it is derived from the large vessels which are arising from the aortic arch, that is from its branches, the brachiocephalic trunk or the brachiocephalic artery, and the left common carotid and left subclavian, and as well as we can say that the branches of brachiocephalic. So the Vasa vasorum in this case, it arises from the large vessels of neck. When we talk about the descending aorta, in the case of the descending aorta, the Vasa vasorum, it arises from the intercostal arteries. The question number 31, it says that the esophagus is entering through which portion of the diaphragm. Now when we see the diaphragm, this is the diaphragm, the inferior view of the diaphragm, which is having the different components. If this is the diaphragm portion, towards the posterior side it is having crusts which are attached to the lumbar vertebrae. This is the crust, it is having right crust and the left crust. The attachment of the right crust is going till lower down, and it is attached till the L4 vertebra. It is attached to L2, L3 and L4, and the left crust is attached only to L2 and L3. So the attachment of the right crust, it is going till lower down. Then if we see the components of the diaphragm over here, towards this portion there is a fibrous structure which is present over here, that is the central tendon of the diaphragm. This is the central tendon. Now the fibers of the diaphragm, they are actually arising from the periphery and they come towards the center, and all the fibers, they are inserted into this central tendon. We are having sternocostal fibers, which are the sternal fibers are arising from the xiphoid process from the anterior side. So the fibers which come from anterior side, these are the arising from xiphoid process, then they are also inserting into the central tendon. The fibers from the anterior lateral aspect as well as from the posterior side, they are arising from the lower ribs. They come towards the center and they are inserting at the central tendon. The rest of the portion which is present at this periphery, it is known as the muscular part of the diaphragm. This is the muscular part. The portion of the diaphragm which extends between the right and the left crust, this portion, it is termed as median arcuate ligament. Now for the openings of the major structures in the diaphragm, we are having three openings. The first opening is present over here. It is located over here. This is the vena cava opening, which for the passage of the inferior vena cava along with the phrenic nerve. This is the first opening, that is the vena cava opening. And if you see the location of the vena cava opening, or for the inferior vena cava, the location is at the central tendon. Then the second opening, the vena cava opening, it is present at the level of T8. Then the second opening is over here. This is the esophageal opening, which is at the level of T10. At the level of T10, it is giving passage to the esophagus, as well as it is giving passage to the vagal trunks, the anterior and the posterior vagal trunks, and apart from this, the esophageal branches of the left gastric artery. Now this esophageal opening, if we see, it is present in the muscular part of the diaphragm. The third opening is present over here. This is the location of third opening. This is the aortic opening, and it is present between the two crusts, or we say it is present behind the median arcuate ligament. So this is the third opening, termed as aortic opening. And the structures which are passing through this aortic opening are aorta, along with that thoracic duct and azygous vein. This opening is at the level of T12. Now for the question, the esophagus, it enters through the esophageal opening, which is present in the muscular part of the diaphragm. So the answer for this question is C. Now the arterial supply for the interventricular septum of heart. For the heart, we know that the arteries which are supplying the heart are right coronary or the left coronary artery, which are arising from the ascending aorta. If we talk about the right coronary artery, the right coronary artery, it is arising from the anterior aortic sinus of the ascending aorta, or we say the right aortic sinus. And the main arteries which are given by this, the main arteries are, it is giving a conus artery. Then along with that, it is giving a right marginal or the acute marginal artery. It gives off acynodal artery. This acynodal artery, it is given in 65% of the cases. Then it gives off AV nodal artery, which is given off in 80% of cases. The posterior interventricular artery. These are the main branches. The conus artery, it is also known as the third coronary artery, and apart from this, it is giving branches to the atrium and the ventricle. Now this right coronary artery, the area of distribution of this right coronary artery is, it will be supplying the main portions of right atrium and the right ventricle. It supplies the whole of the right ventricle except the portion which is adjacent to the anterior portion of interventricular sulcus, because in that sulcus the anterior descending artery, the left anterior descending artery is running, which will supply that portion of right ventricle. So that small portion of right ventricle is not supplied by right coronary artery. Then it supplies some portion of left ventricle. For the left ventricle, it supplies the portion which is towards the posterior part of interventricular sulcus, the portion which is adjacent to that. Apart from this, it is supplying SA node in 65% of cases, in 65% of population. AV node is supplied in 80%. Then apart from this, the bundle of His and the right bundle, the left bundle. The bundle of His and the left bundle, they are partially supplied over here because they will be also supplied by the left coronary artery. In this we can see that the right bundle branch, it is not supplied by the right coronary artery. Now apart from this, the right coronary artery, it supplies the posterior 1/3 portion of interventricular septum. Because in the posterior 1/3 of interventricular septum, posterior interventricular artery is running over there, so it supplies this posterior 1/3 part. So this is the area which is supplied by the right coronary artery. Now if we talk about the left coronary artery, the left coronary artery, it is arising from the posterior aortic sinus, the left posterior aortic sinus, and then it gives off the main branches. One branch is the left anterior descending artery or the left anterior interventricular artery. Apart from this, it is giving the circumflex artery, as well as it gives the diagonal artery. Now the area which is supplied by the left coronary artery, it mainly supplies the left atrium as well as it supplies the left ventricle. It supplies all the portion of the left ventricle, just some portion which is towards the posterior side adjacent to the interventricular groove, except that portion. Then apart from this, some portion of right ventricle is supplied. The portion of the right ventricle which is just adjacent to the interventricular groove, that is supplied by it. Apart from this, it is supplying the anterior 2/3 of the interventricular septum, which is being supplied by left anterior interventricular artery. Then it supplies the SA node and AV node. The SA node in 35% cases, AV node is being supplied in the 20% of cases. So that means SA node and AV node, they are mainly supplied by the right coronary artery. The major portion of bundle of His is supplied by the left coronary artery. Apart from this, it is supplying the left bundle branch, as well as this is the one which will be supplying the right bundle branch. So these are the structures which will be supplied by the left coronary artery. Now if we come back to the question says the arterial supply of the ventral 2/3 part of interventricular septum, it will be supplied by. The answer for this question is B, left coronary artery, because this portion of interventricular septum will be supplied by the anterior interventricular artery, which is a branch of left coronary artery. In this question, we have to identify the nerve at A point, at the B point. Now first of all, we will see this picture. This picture is towards the axilla portion of the upper limb, and the muscles which are being shown over here. This muscle is a subscapularis muscle. The muscle which is shown over here, this is the latissimus dorsi. Now these points are on the nerves or the branches of the brachial plexus. If we see the A branch is towards the upper subscapular nerve. A is the upper subscapular nerve. This nerve is going upwards like this, and it will be supplying the subscapularis muscle. Now another landmark B. B over here, if you see, this nerve is going lower down, it is going towards the latissimus dorsi. This is the thoracodorsal nerve. The thoracodorsal nerve, also then termed as nerve to latissimus dorsi. Then apart from this, there is a small nerve going like this. This nerve is the lower subscapular nerve. This one is the lower subscapular nerve. Now in this we can see all these are the branches of the posterior cord of the brachial plexus. 3 branches already mentioned, upper and lower subscapular nerve and the thoracodorsal nerve. Now if we see over here, C. The C is marked like this. This is the nerve which is going over here. C is the axillary nerve. C is the axillary nerve. Now in this, if we see this C nerve, it is going towards the neck of the humerus, surgical neck of humerus, and it is passing through the quadrangular space, intermuscular space, which is present over here. The D nerve, which is going like this is the D nerve which is over here, and it is going behind or towards the posterior aspect of the shaft of the humerus. This nerve, it is entering through it is passing through the lower triangular intermuscular space. This nerve D is the radial nerve. D is the radial nerve. All these nerves, these are the branches of the posterior cord, and if we see the question says that you have to identify the nerve at the marker B. The B is thoracodorsal nerve for the latissimus dorsi. The answer for this question will be B, that is a thoracodorsal nerve. The next question, in this question you have to identify the marked dermatome. If you see the dermatome for the lower limb, this picture is showing the dermatome of the lower limb. Towards the anterior side, if we see, towards the anterior side for the lower limb, regarding the dermatome, it is from L1 to S4. Now if you see the L1, this is supplying, or this is present towards the area which is just below the inguinal ligament. This much area is by the L1, then below that L2, and towards the knee we are having the L3 portion. This is the L3. The L3 is supplying the area near the knee. Then as we come towards the leg, towards the medial side we have L4, which is continuing till the great toe over here, and towards the lateral side we are having the L5. If we see towards the foot, this L5 is continuing towards the 3 middle toes, and towards the lateral most side over here we are having the S1 dermatome. So towards the foot, the most medial side by L4, in between L5, and the lateral most side by the S1. The same is for the sole, L4 for the medial side, in between L5, and the lateral most side is by the S1. Now this S1 is continuing towards the heel also. So at the heel also we have the S1 dermatome, and if we see towards the posterior aspect of the lower limb, there is a strip of dermatome which is present along the whole of the lower limb. And if you see over here, this is the strip, and this is the S2 dermatome, which is extending towards the posterior aspect of leg, as well as towards the popliteal fossa and towards the upper side, towards the back side of the thigh, and it is also present towards the lowermost portion of the gluteal region. This dermatome over here is the S2, and apart from this, towards the perianal area, this is the perianal area. The dermatome for the perianal area is S4, and around the S4 the region over here is supplied by the S3. So these are the various dermatomes of the lower limb. And if we come back to the question is pointing over here. This is the posterior aspect of the lower limb, and this posterior strip over here, the dermatome is S2. So the answer for this question is D, S2. Regarding the superior cervical ganglion, now when we talk about the ganglion which are present in the cervical region, initially we are having the 7 ganglion for each of the, it is C1, C2, C3, C4, C5, C6 and C7, and last is C8. These are the ganglions which are initially present, and later on the upper 4 ganglion, that is from first to this fourth, they unite to form the superior cervical ganglia. So therefore the gray rami communicant, they will be arising from the from C1 to C4, they will be arising from the superior cervical ganglia. The next two, that is C5 and C6, they unite to form the middle cervical ganglia. And the lower two, they unite to form inferior cervical ganglia. In this, the largest one is the superior cervical ganglia. If on the lower side, the C8 and T1, these two ganglions, if they unite, they are termed as stellate ganglia. So now if we come to the question says for the superior cervical ganglion, now we know that it will be giving rise to gray rami communicants from C1 to C4. So that shows that the answer is A. Lacrimal gland. For the lacrimal gland is getting its supply from the pterygopalatine ganglion or the sphenopalatine ganglion. It is giving the parasympathetic supply as well as sympathetic and the sensory supply. Now for regarding this secretomotor supply of the lacrimal gland, it will be arising from the lacrimatory nucleus, and from the lacrimatory nucleus it passes through the sensory fibers of the facial nerve. So it is passing through facial nerve. Then from the facial nerve it passes the fibers, they are passing through a branch of the facial nerve which is greater petrosal nerve. This greater petrosal nerve, it unites with the deep petrosal nerve and it forms the median nerve or the nerve to pterygoid canal. This median nerve, it passes through towards the pterygopalatine ganglia, and from the pterygopalatine ganglion, now the nerve fibers, they relay in the pterygopalatine ganglion, and the postganglionic fibers which arise from here, it will be passing through the maxillary nerve, the zygomatic branch of maxillary nerve, and then the zygomatico-temporal branch, this zygomatico-temporal branch, it goes towards the lacrimal nerve, which will finally supply the lacrimal gland. So in this, if we see the nerve, the main nerve which is involved over here, the branch of the facial nerve which is involved is the greater petrosal nerve. So the answer for this question over here is A, which is the greater petrosal nerve. It is the one which is carrying the parasympathetic fibers to supply for the supply of the lacrimal gland. Now if you see the lacrimal gland is a J-shaped structure and it is indented by the levator palpebrae superioris. In the bony orbit, if these are the bony orbits, the lacrimal gland, it is present in the lacrimal fossa. This lacrimal fossa is present towards the lateral side and it is present at the roof of this bony orbit, the anterior lateral portion of the roof. The lacrimal gland is present over here. The secretions which are formed in the lacrimal gland, it passes towards the conjunctival sac. So from the lacrimal gland, the secretion or the tears which are formed, they pass towards the conjunctival sac, and from the conjunctival sac through the punctas, it is passing through the lacrimal canaliculi, then towards the lacrimal sac. Now this lacrimal sac, it opens via the nasolacrimal duct. It opens up into the inferior meatus of the nasal cavity. The nasolacrimal duct, it will open in the inferior meatus of the lateral wall of the nasal cavity. Question number 37 says that identify this lymphatic structure. Now in this, if you see this lymphatic structure, we can see a lymphatic nodule is present over here, and just above over here towards the surface we are having the epithelium with the various nuclei over here. This is a slide of the tonsil. It is a slide of the tonsil. If we see the picture over here, same picture, the characteristic feature of the tonsil is that it is having lymphatic nodules which are present towards the outer side, and over it, it is having the epithelium. The presence of the epithelium is a characteristic feature of the tonsil. The epithelium which is present over here is a stratified squamous epithelium. Stratified squamous epithelium. Now if we compare it with the other structures like spleen, thymus or lymph node, how do they appear? The histological picture. Now this is the histological picture of the spleen. Within the spleen, we are having the red pulp and the white pulp. On the outer side, the capsule is there, then it is sending the trabeculae present over here. The red pulp is the portion which is over here. This whole is the red pulp having the splenic cord of cells, that is the Bildorf cords, and in between we are having the splenic sinusoids filled with the blood. Now this portion where the lymphoid aggregate is there, it is termed as the white pulp. And the characteristic feature of this white pulp is that this lymphoid aggregate is around the central arteriole. It is also termed as pulse, that is peri-arteriolar lymphatic sheath. So this is a characteristic picture of the spleen. When we compare it with the lymph node, this is the lymph node slide. The lymph node slide, it is having a capsule, and just beneath the capsule we are having the subcapsular sinus. The space which is present over here, this is the subcapsular sinus. Then it again sends, the capsule sends trabeculae towards the inner aspect, and it divides the lymph node into the outer cortex region, and towards the inner side we are having medulla region. In the medulla region we are having the sinusoids and the medullary cord of cells. Towards the cortex we are having the lymphoid nodules, which is apparent like this. And if you see the lymphoid nodules over here, which is the aggregate of lymphocytes, towards the center we are having a pale staining area, and this is the germinal center. When we compare it with the slide of the thymus, this is the slide of thymus. In the thymus, towards the outer side we are having a dark staining portion, which is the cortex. This is the cortex region towards the outer side. On the inner side, the light staining area is known as medulla, and this light staining medulla, it is characterized by pink bodies which are present over here, and it is termed as Hessel's corpuscle. The pink bodies which are present over here, it is a characteristic of the thymus, and it is known as Hessel's corpuscle. So by differentiating these features, we can identify the slide of the various lymphoid organs. The question number 38. The question number 38, it says regarding the anterior choroidal artery syndrome. For the anterior choroidal artery, the anterior choroid artery, it is a branch of the internal carotid. The anterior choroidal artery, it is a branch of internal carotid artery, and it will be supplying the various portions of the internal capsule. Now the portion of the internal capsule which will be supplied by this is majorly, it is supplying the posterior limb, as well as it is supplying the retrolentiform and the sublentiform part of the internal capsule. The sublentiform and retrolentiform part of the internal capsule. Now in the posterior limb, the main fibers which are passing through the posterior limb, it is consisting of all the motor and the sensory fibers. Then towards the sublentiform we are having the auditory fibers, and in the retrolentiform part we are having the visual fibers. So if this artery is affected, if there is ischemia of this artery, if there is obstruction of this artery, it will lead to ischemia of all these structures, and it will affect the sensations which will be carried by this. Now if we come back to this question, the question says that all things are present in the anterior choroid artery syndrome except hemiparesis and hemisensory loss will be there because it involves the posterior limb which is carrying the motor and the sensory fibers. Homonymous heminopia will be there because it will be affecting the visual fibers which will be passing through the retrolentiform part. This option is not correct because the anterior choroid artery is supplying the posterior limb and not the anterior limb. So the answer for this question is C. The anterior limb, towards the anterior side, the anterior limb is basically supplied by the Huebner's artery. The next question is the one which is regarding the arterial supply of the internal capsule. Now for the internal capsule, first of all, the internal capsule, it is a V-shaped structure. It is having anterior limb. This portion is the anterior limb. Towards the posterior side, we have this portion which is the posterior limb. This portion is the posterior limb. So this is the anterior limb. This portion is genu, and this is the posterior limb. These are the parts of this V-shaped internal capsule. Apart from this, we are having sublentiform and the retrolentiform portions. So these are parts of internal capsule. and the other parts are retrolentiform and the sublentiform part. Now the nucleus which are present just around this, towards the medial and the anterior side we are having the caudate nucleus. This is towards the medial and anterior side, the caudate nucleus is there. Then towards the posterior aspect of medial side we have the thalamus. So A is the caudate, head of caudate nucleus, B is the thalamus. They are forming the medial boundaries of the internal capsule, and towards the lateral side we are having a triangular nucleus which is the lentiform nucleus. The lentiform nucleus, it is formed by the globus pallidus and as well as the putamen. Now when we talk about the arterial supply of all these structures, the arterial supply is mainly by the middle cerebral artery. The middle cerebral artery is supplying the anterior limb, genu as well as the posterior limb. When we talk about this middle cerebral artery, it is supplying the first, second and the third portions, and it is supplying it by the lenticulostriate branches. Among these lenticulostriate branches, one of the largest lateral striate branch, it is known as the Charcot's artery of hemorrhage. It is known as Charcot artery of hemorrhage because this is the artery which is most commonly ruptured. So that is why it is termed as the Charcot artery of hemorrhage, and it is given off by the middle cerebral artery. Apart from this, the rest of the supply, the anterior limb, it is supplied by a branch of the anterior cerebral artery which is the recurrent branch. The recurrent branch of anterior cerebral artery, and it is known as Hübner's artery. The genu, it is supplied by the direct branch from internal carotid artery. Then when we talk about the posterior limb, retrolentiform part and the sublentiform part, they are mainly supplied by the anterior choroidal artery. So this is the supply for the internal capsule, the various portions of the internal capsule. Now we come back to this question. It says that all are true regarding the supply except the anterior limb is supplied by recurrent branch, that is the Hübner's branch of anterior cerebral, this is correct. Genu is supplied by internal carotid, correct. The posterior limb supplied by anterior choroidal artery, it is also correct. The sublentiform and the retrolentiform part, they are supplied by again by the anterior choroidal arteries. So this option is wrong, and the answer for this question is D. Now the question number 40. The question number 40, it is showing the ascending tract. The ascending tract which is being shown over here is the dorsal spinocerebellar tract. Now this dorsal spinocerebellar tract, it is carrying the unconscious proprioception. It begins from the periphery and it reaches to the first order neuron for this is dorsal root ganglia. And this dorsal root ganglia is present in the dorsal root. Now if over here we see the picture over here, from the periphery the fibers are coming. Now if you see this picture over here, the fibers are coming from the periphery over here. The fibers are coming like this. They are going towards the spinal cord. These are the fibers coming from periphery, and this is the position of dorsal root ganglion. So the B which is being marked over here is the dorsal root ganglion present in the dorsal root. Now the fibers, now it is going towards the spinal cord and they relay over here in a nucleus. The nucleus which is the second order nucleus. So the second order neuron for this tract, the second order neuron is the Clark's column. It is a Clark's column which is present over here, and this Clark's column, it is present in the Rex's lamina 7. Now the fibers, as they are ascending upwards, the second order neuron, the axons of this will ascend upward, and it is going towards the cerebellum through the inferior cerebellar peduncle. So the C structure which has been shown over here, this C is showing the tract, the dorsal spinocerebellar tract. A we have already discussed, this is the nucleus, that is the Clark's column. And D over here is showing the inferior cerebellar peduncle, through which these fibers are going towards the cerebellum. So these are the various portions of this dorsal spinocerebellar tract. And if you see the Rex's lamina, regarding the Rex's lamina, this is the picture showing the Rex's lamina, which is in the grey matter of the spinal cord. And the Rex's lamina, it is divided into 10. Starting from 1st to the 10th. Now the first, which is beginning over here, this first is for the posterior marginal nucleus. The second is for the substantia gelatinosa. Then third and fourth, and the fourth is for nucleus proprius. The fifth and sixth, they are forming the base of the dorsal column. They are forming the base. Then seventh over here, seventh is for the Clark's column, which is the nucleus for this dorsal spinocerebellar tract. The ninth and the eighth and ninth, they are forming the medial and the lateral nucleus of the anterior column or the anterior horn of the grey matter. And towards this side, this 10th, it is forming the grey commissure. It is forming the grey commissure, and as well as at this point the substantia gelatinosa centralis is present over here. So these are the locations of the lamina and the various nucleus which are present in each lamina. Now if we come back to the question says A is a nucleus present in Rex's lamina 7th, which we have already mentioned that yes, this is the Clark's column present in Rex's lamina 7, so this option is correct. Next is B, carrying the conscious proprioception from lower limb. It is actually carrying the unconscious proprioception from the lower limb, so this is not correct. C is lateral lemniscus pathway, this is the dorsal spinocerebellar pathway. D says it enters cerebellum through middle cerebral peduncle, but it is entering through inferior cerebellar peduncle. So the answer for this question is A. Question number 40, the answer is A. This completes till the question number 40. Thank you.